Hello, I'm Skai. I will be doing my BE trigger now. So first of all, you want to get your room set up. You want everything detented, kind of like a normal, in general, way that you get ready for x-rays, as we normally do. And make sure that you have all the IRs and everything that you need as well. So in terms of the supplies that you need for a barium enema, you're going to need the barium enema bag. This right here. It is also going to have the tube and the tip at the very end. And for a lot of BEs that we do these days, especially if it's double contrast, you want a double lumen so that you can tip the patient only once and you can inject barium and air as needed and you don't have to tip them twice. So this one is not a double lumen, but we'll pretend like it is for this situation. And so normally with this tip, it has two tubes coming on either side. And the main one is for the barium to go through. And there's going to be one that is the cuff inflator, and you only want to squeeze that once, and the balloon is going to inflate. You want to make sure before you start the exam that the balloon inflates properly. And you just need one squeeze, and then you can let it go, and it'll deflate back to its normal deflated self. And then on the other side, you have the air infuser, and that's going to be for when the radiologist pumps air into the colon, and he'll be doing that a few times. Also, what you're going to want are some lubricant for the tip. Sometimes it comes in little packets like this. You're also going to want a hemostat as well as some gloves. Typically, it would be a good idea to have 2 pairs of gloves so that in case it gets a little messy, you can take the top pair off and you're still covered with a clean pair of gloves. You also want some extra towels for your patient, especially at the end of the exam when they need to go to the bathroom, which should be locked if there are 2 doors. Just make sure that it's secure for the patient and that it's ready for that patient so that no one else is going to be using the bathroom and they can have their privacy at the end. And usually, in general, it would be safer for the radiologist once the tip is inserted to do the inflation of the balloon, him or herself. But otherwise, the radiologic technologist can do that as well. When you are done with getting all of your supplies, getting your room set up and everything, you can go out and grab your patient. You want to double ID them and first introduce yourself, tell them where you're from, double ID them, the name and the date of birth. You want to ask if they're pregnant, if they're female, and also just kind of ask them if they have done any prep work for this particular exam, like fasting or doing any cleansing enemas. And at this point, you also want to explain the procedure to them so that they kind of understand what's going to happen. And the radiologist will give them a little bit more information kind of as the exam goes forward. So that's okay. So before I get the barium all mixed up, we're going to be taking our scout image, and that's basically just a KUB just to make sure that the patient has prepared and cleansed their colon as much as they can by fasting and or doing like a cleansing enema. And so once the scout image is taken, then I'll be getting my barium enema bag here. We're going to be putting some either lukewarm water or cold water, which helps reduce the chances of cramping. And so we want to open the opening. And for the most part, it depends on how thick you want the barium to be, but 500 milliliters should be okay for a double contrast study. We'll go ahead and fill this up to 500 milliliters, and there's a little mark here on the bag to let you know when you're done. A little bit more. Okay. Okay, so we are there. And just make sure that before you let the tube down that it's clamped, nice and closed. Go ahead and mix the barium around. Make sure it's mixed well enough with the water. Make sure you close it, then you don't want to get it all over your face. There we go. Okay. And so a very important step that you need to make sure that you do before you insert the tip is that you want to bleed the line. So right now there's a lot of air in it, you can see, and the barium has already started going down, so you want to make sure that the line doesn't have any air in it. So in order to bleed the bag, you need to undo the clasp and let a little bit fall into the trash can. Go ahead and raise the bag up. You undo the clasp. You can see it's going to be running down. There we go. Okay, and then you go ahead and clasp it again. That's all ready to go. All right. I have my patient in the Sims position right over here. And so she's relaxing over there for me to start. Okay. So the bag should be no more than 24 inches above the anus. And what we're going to do is lube the tip up before we insert it so that it goes in a lot easier and is much more comfortable for the patient. And also have the patient take in some nice deep breaths, and usually on the second breath when they inhale, as they're exhaling, you can insert the tip. So let's get started. Okay, Sarah, so I'm going to go ahead and start. Go ahead and take a nice deep breath in and blow it out. And then another nice deep breath in. You're going to feel some pressure. Go ahead and breathe out, and the tip goes in. And so when you insert the tip, it's going to be 1 to 1.5 inches anteriorly towards the belly button, kind of more like this, and then superiorly. And no more than 4 inches in. That's very important. No more than 4 inches in. And then at this point, you're going to go ahead and inflate the balloon. And you already know that it is inflating properly because you tested it before. So just one pump inflates the balloon. It's about 90 milliliters of air. And it's ready to go. And sometimes the tip will go in just a little tiny bit as the balloon kind of settles in and anchors itself where the sphincter is. So don't be alarmed by that. That's normal. And I'll just let the patient know that they're going to feel some pressure when the balloon inflates so that there are no surprises. Okay, so then at this point, the radiologist is going to step in, and he's going to do some of his images that he needs to do. And the barium is going to go in and to the left colic flexure. And then at that point, they're going to drop the bag down onto the table so that there's no more gravity to let it flow. So once it hits the left colic flexure, they're going to have some of the barium is going to flow back through the tube and into the bag, and that's perfectly okay. That happens. But you're going to, after that happens, then you want to clamp the tube again and have the patient roll over onto their left. So let's just make sure that the tube is nice and secure. Okay, so once we had the patient was lying on her left side, we injected the barium into the descending colon, and it goes up to the left colic flexure. And once that happens, some of the barium will kind of have a backflow. There will be barium still in that colon, but at this point, we're going to clamp it. We're going to have the patient roll over onto their right side in a right lateral decubitus position. And what this does is, at this point, the radiologist is going to pump air into their descending colon, and that kind of pushes the barium from the left colic flexure through the transverse colon over to the right colic flexure, and then down the ascending colon. And that just kind of helps to coat the walls of the colon. And once they see that the barium has coated the appendix and the terminal ileum, we know that it is sufficiently coated, and at that point they can take their spot films. Once they're done with their spot films, that's when we step in again, and they will be ordering the overheads that they request for this particular patient. And so the tube stays in the rectum this whole time, and we do not remove it. And so let's get started. Okay, so we've started the exam. The first projection is going to be the AP projection, and the patient is in their right lateral decubitus position. The central ray is at the mid-sagittal plane, so the midline of the body right here, and the It's going to be at the level of the iliac crest. So right about here, I have my marker at the top of the IR, and since her left side is up, I'm going to mark that side. And I'm using a 14 by 17 plate. It is also important to still shield as much as you possibly can. And so the shield was underneath her at the beginning since we were doing the fluoro studies, but now that we're doing X-rays again, we're going to be shielding. There we go. Thank you. I'm just going to there. Make sure that it's out of the light field, and also that their arms are out of the field as well, so that they're not in the picture. All right, so I'll go ahead and shoot that. For technique-wise, I would probably use 80 to 85 kbp, and then depending on their body size, around 20 to 30. I think for Sarah, I'd probably use closer to 20 mass. And so then, at this point, we're going to go ahead and we're going to be positioning everything for the lateral projection. All right, let's do that. Make sure that it's at 40 inches again. I'm going to take the IR out. I'm going to put a new IR into the table. Make sure the bucky is lined up with the tube, as per usual. So we have the tube all detented and happy. It's ready to go. We have an IR in the table bucky ready to go. Since her right side is down and we're doing a vertical beam, I'm going to be using my right marker. So we'll put that kind of in the light field. Make sure that you can see it. And so the mid-coronal plane is going to be where the central right is, and then at the level of the as is. And so in terms of technique, I would increase kVp a little bit and then keep my mass closer to 20 for her. So that would be like 85 to 90 kVp. And yeah, like I said, closer to 20 mass for her. So go ahead and take the x-ray. So my patient is still in her right lateral D-cube position. And what we want to do is start rolling her forward so that she is in an RAO. So go ahead and just roll towards me. You can put your hand a little bit more. Okay. Make sure their arms are still out of the field of vision. And then, so her right knee can come up, and then the left leg can go down, just like that. It's kind of like a Sims position at this point, and the rotation of the body is going to be 35 to 45 degrees. And I'm going to go ahead and have the CR, the central ray is going to be at the level of the iliac crest, and then also about 1 to 2 inches lateral from the midline of the body. So towards us this way, closer to about there. Iliac crest, we'll be raising that up. Okay. And so since her left side is closest to me, it's just easier for me to put my marker down on that side. Just make sure that that's all correct. And for each one of these, projections, the breathing technique is just going to be hold your breath. Very simple for each one of these. We are also using a 14 by 17 IR. So she's also shielded, as you can see. And the technique for this one, I would say probably leave it around 20 mass for her, between 20 to 25 mass. So we'll go ahead and take it. So we're going to be doing the PA projection now. She's in the RAO position, and I'm going to need her to be in the prone position at this point. So Sarah, go ahead and straighten this leg out, bring this head down. Okay. So for the PA projection, the central ray is going to be at the mid-sagittal plane, entering at the level of the iliac crest. And then since her left side is closest to me, I'm just going to use my left marker, and I'm going to put it in the upper corner just so that we are out of the anatomy of interest. Like that. And for this projection, it's going to be 40 inches. All of them are going to be 40 inches for the SID, and the IR is going to be 14 by 17. All I have to do is have her hold her breath and take a picture. So Sarah, just hold your breath. Okay, so that was the PA. Now we're going to move on to the PA axial projection, and it's going to be a 30 to 40 degrees. For the PA, it's going to be caudad, so down towards the feet. So for this one, just make sure that your bucky is aligned up with the tube. Make sure you have a new IR in there. Make sure that you run the one that you took the PA on. And for this projection, the central ray is going to be again at the mid-sagittal plane, and it's going to be entering at the as-is, but you want to make sure that the light curves around at the as-is and you're not just starting it from the top of the body. So I'm going to bring it down a little bit. Right about there. And for this projection, this one's really good to see the rectosigmoid area. And all you have to do for this one is just have the patient suspend their breath. So Sarah, just hold your breath and beep, X-ray. Go ahead and take your IR out, and we're ready for the next one, which is going to be for her. I would say in terms of the technique-wise, since there's more distance from the tube to the bucky and the object, I would increase it. So that would be from the PA, which would be like an 80 at 20. I would increase it to 85 at 20, maybe even bump up the mass just a little bit. And so from here, we're going to have Sarah move into an LAO. So Sarah, go ahead. You can have your hand back this way and roll towards me a little bit. You can kick that knee out just a little. And then for this one, just make sure that their shoulder and their hip are lined up together so that their body isn't twisted in any way. Just make sure a little bit closer to you, just like that. And bring your tube back. If the shield falls, that's okay. Just put it back on. Make sure that your tube and your bucky are aligned again after you're done with the axial projection. And we'll start the projection for this one now. Make sure the bucky is aligned every time that you have a tube angle, and also when you take the tube angle off. And so the central ray for this is going to be 1 to 2 inches lateral from the midline on the elevated side, and it's going to be centered at the iliac crest. And so for this one, since her left side is closest to me, just for ease, I'm going to mark that side. Once again, make sure that it's not in any of the anatomy. For this one, I would increase the technique a little bit, again, since now there's a little bit more OAD and more matter to go through. So I would say 85 at like 23 or so, maybe closer to 24, 25. And then go from there. The breathing technique for this is just going to be suspend the breath. So Sarah, just go ahead and hold your breath. Ding. Take the X-ray, take the IR out, put a new one back in, and we're ready for the next one. So at this point, we're going to be getting her into a left lateral decubitus position, and we'll be taking 3 images from there. So I'm going to roll over onto your left side, make sure the bag is out of the way so that they can move. And go ahead and stack your knees together. Perfect. We'll just put that there, put the shield on. Okay. And just adjust it so that they're in true lateral. Make sure everything is lined up. Make sure that their hips and their shoulders are perpendicular to each other or parallel, just at the same angle. All right. So, so now that her left side is down, I'm going to be putting my left marker here, right next to her. And so for the lateral projection, the central ray is going to be at the mid-coronal plane, and it's going to be at the level of the asses this time. Okay, so right about there. Marker is not in any anatomy. And so we're still using a 14 by 17 IR. The SID is at 40 inches still. And the breathing is just going to be suspend the breath. The technique is going to be increased for this one because there's more matter to go through. And so I would increase it to about between 85 and 90 and then 25 mass for her. And so Sarah, go ahead and hold your breath. Ding. Okay, so that's that projection. And she's going to stay in this left lateral projection for the next two. So take the IR out, go read it, put the new one back in. And so for the next projection, that's going to be the PA projection. So we need to get an IR into the holder. This is going to be cross table. Okay, so once again, for this one, we're using a 17 by 14 IR. The central ray is going to be the mid-sagittal plane, and it's going to be at the level of the iliac crest this time. There. And since her left side is down, I'm going to use my left marker. Make sure that it's not in any anatomy. And it's at 40 inches SID. And for this one, I would decrease the technique again because now we're shooting at PA, and so that's less matter to go through. So I would bring it back down to 80 at 20. And I changed my mind. I'm not going to be using my left marker because it is going to be cross table on the IR. So since our right side is up, we're going to use the right marker, and we're going to put it directly onto the imaging plate. And she is in her left lateral decubitus position, and we're shooting a PA projection. So Sarah, go ahead and hold your breath. Ding. Okay. So we take the IR, we go read it, and we have one more projection to do. And that's going to be the lateral rectum. You can also do this while you're doing your regular lateral projection. You don't have to move the tube so much. That would be ideal. So we'll get this all lined up again. So make sure that the puppy is lined up with the tube. Looks good. She's in true lateral position. And so the central ray for this one is going to be, so the central ray for this position is going to be the mid-coronal plane. And it's going to be at the level of the asses. And you can cone down on this one because the only thing that we're interested in is the rectum. So we can bring it down to a 10 by 12. There we go. Okay, right about there. Since our left side is down, I'm going to be marking the left side. All right. And for this one, we have coned down, and it's going through a lot of bone from the pelvic bone through the ala of the ilium. And so I would increase the technique a little bit for penetration to get through the bone. So I would bring it up to 90 and then have the mass be about 25 or so. And the breathing is just suspend breathing. The SID is still at 40 inches. And we have the 10 by 12 IR in the table ready to go. So Sarah, go ahead and just hold your breath. Ding. And that should be the very last image that we take. So you just need to go make sure that we have all of the anatomy in there, and then it should be good to go. And the next step before we end the exam, we'll be taking the tip out, and we'll discuss that right now. Okay, so we're ready to take the tip out. We're going to have the trash can ready to go right here. Before you do anything, the most important thing that you have to remember is to deflate the balloon before you try to take it out. So go ahead and just deflate the balloon, okay? So I have tape on her leg, so it's going to be, okay, got it. Okay, so at this point we've deflated the balloon, everything's ready to go. You immediately slide the tube out, give them a towel. Make sure that if your table is really high, that you have a stool ready for them so that they can get off easily and not fall off. Okay, so Sarah, I have this towel here for you. You can go ahead and roll over, and I've got the bathroom ready to go for you. Okay. Oh, and let me get this out of your way before you stand up. Great. And that is the end of the exam. And she's doing just fine. Look at her. She looks great. Okay, so we just found some tools that we did not have for the exam that we would normally have. And so that's going to be the double lumen tip, you can see here. And so it has the main tube for the barium on this side, and then this little tube right here actually is for the cuff inflator. And this one you can use multiple times, but this one is single use. And so for the cuff inflator, before you start the exam, or any time before you tip, you just want to make sure that the balloon inflates properly. And so right now I have it unclipped, so it's open. You just want to give it a nice squeeze. It blows up the balloon. This one doesn't seem to work properly. I think it's defective. But you're going to go ahead and just clamp that down so that the balloon stays in place. And it's supposed to stay inflated. I guess there's a hole in it or something right now, but anyway. So it's all clamped, and so it should stay inflated. The other item that we have is the hemostat here, forceps. They do lock in place so that they stay closed, but other than that, you can grab things. I've never used it. So. We also have the air infuser, and so this normally connects with the tube, and this just allows the radiologist to pump air into the colon for a double contrast study. And so that's pretty easy. This one doesn't seem to have a lumen for that, but usually it's on the other side. And that's about it. We're ready to go.
Okay, so we're going to start talking about the images now. So the first position that we had our patient in was the right lateral decubitus position, and we were shooting it as an AP projection. This one you can see here, it shows the colon full of contrast. The anatomy that we're looking for is the side up in the ascending colon, which is on the medial side, and also the lateral side of the descending colon. And you want to make sure that the patient is in the true lateral position, and to do that you can just measure to make sure that their shoulder and their hip are aligned together, to make sure that they are not twisted or rotated too much in one direction. Make sure they're in true lateral position. The next one that we'll be looking at is the PA oblique projection. So for this one, the patient is going to roll over onto their right side, 35 to 45 degrees rotation into the RAO position. And for this one, it shows the right colic flexure open with less superimposition, and also the ascending colon and the sigmoid portion as well. The next one after that is the PA projection. So we have the patient roll over onto their stomach into the prone position. This one shows the whole colon, including both flexures. The spine is centered to the IR, and the central ray enters the mid-sagittal plane. And after that one, the patient stays in the prone position, and we're going to be taking the PA axial projection. And this one shows the rectosigmoid area. You can also, for this one, cone down to a 10 by 12 if you want. It shows the rectosigmoid area with less superimposition than the PA, the normal PA. And the central ray is directed 30 to 40 degrees caudad. So for the PA, it's caudad, and then for the AP, it would be cephalad. The transverse colon and the two flexures don't always need to be included in this particular one because we're mostly interested in that rectosigmoid area. The next position, you have the patient roll over onto their left side, 35 to 45 degrees into the LAO position. This is going to be the PA oblique projection. And this one shows the left colic flexure open and not superimposed, as well as the descending colon. The next one after that is the left lateral position. So the patient rolls over completely onto their left side, and it's going to be the lateral projection. This one shows the rectum and distal sigmoid colon the best. The hips and the femurs need to be superimposed. So once again, make sure that the patient is in true lateral. Make sure that their shoulders and their hips align so that they're not rotated or twisted in any way. If the rectosigmoid area is of most interest, the rest of the colon doesn't really need to be shown. And you can also cone that one down to a 10 by 12. Let's see here. And then we're going to go and do the left lateral decubitus position still, so that they can remain where they are. And this is the last image that we'll be taking for the series and evaluating the images. You'd also do a regular lateral projection as well for that side. But while they're still in the left lateral decubitus position, we're talking about the PA projection. This one shows the side of the this one shows the lateral side of the ascending colon, which is the side up. It also shows the medial side of the descending colon. And then the very last image is just the post-evacuation. It can be AP, it can be PA, either prone or supine. It's basically like a KUB, center at the crest, mid-sagittal plane, and it's just to check for adequate evacuation and make sure that the patient is getting rid of the barium properly and everything like that after they evacuate their bowels. And that's the last one that we can evaluate here. Thank you so much for watching my video. Bye-bye.